And those who are coming, they'll come back and join here. So I want everyone to be back now, okay? And then we'll go ahead and start. So I want you, all right, so everyone, we talked about the injections, and everyone should know your IM injection. Now I will go on sub-Q. Sub-Q, where do we use? For apogen. Remember, I said apogen, where do we give apogen? What drug, we did apogen, where do we give apogen? To increase red blood cell. And which patient do you give? Anemia. I want you to write down, so every time we must know. Apogen, very important for us to know, is given how is for patient by IV, and the apogen is given is for patient with dialysis, renal failure patient. Why renal failure patients are? Because they have low hemoglobin and they are very anemic. So what are you treating apogen for? Anemia. What is it increasing here? Red blood cell. What blood test would you do? Hemoglobin and red blood cell. Neupogen. What is Neupogen? I did that. To increase white blood count. So write down there, to increase white blood count. Heparin, Lovenox, and Fragmin, all these are your blood thinner. So heparin, you can give IV and you can give sub-Q. Fragmin and Lovenox is given only sub-Q. Okay? Now, sub-Q is slower absorption than IM. We did earlier, which is the faster when you're putting in the order. So remember, sub-Q is smaller. And you can give them in abdomen, you can give them in thigh, and those are common site, we use them. No more than 1 ml, here again. And what is the, is rotate the site. 45 degree, not 40, 45 to 90 degree. You can also use, when they have large muscle, you can go for 90 and you can go 45. The size of needles you have at the last, 5/8 and 25 gauge needle. Intradermal. Intradermal, we are checking for PPD when you're giving for allergies. So write down PPD. And you're giving some of the skin testing. Do not aspirate them. Very small volume to give them, like 0.1 ml. Not even 1 ml. 1 ml is a lot because you're checking allergies. 0.1 ml. Watch for, when you give intradermal and you're checking allergies, what do you monitor? Anaphylactic reaction. Size of needle, you have 3/8 and 5/8, 25 gauge and 15 degree you can give. How do we give here? 15 degree, 10 to 15 degree you can give them intradermal. Everyone make sure we all know your site and this. IM injection. IM injection, check for the blood, aspirate them, and you're giving 90 degree angle. Z-track. Where do we use Z-track? For iron, right? And you're giving IM. What is the needle size for Z-track injection? 1 to 1.5 inches of the needle. So what is the needle size? Should be a little longer, 1 to 1.5 size. So everyone must know your injection. Questions are going to be, you're giving heparin. Question may be on your apogen, neupogen word, and Lovenox, Fragmin, all these drugs, we all should know where do we use them and how do we give them. Now you guys all have done, only I'm bringing up the main points here. And you all should know your injection technique. Question can be how you give injection, how do you give sub-Q, what is the needle sizes, how much fluid you can give them. Next is pulse in your procedures. I'm moving on the pulse. And how long you should check the pulse is 60 seconds, 1 full minute you check the pulse. Radial pulse and ulnar pulse. What did I say? Radial and ulnar pulse is important to check. Remember, I said earlier, ABG word. I want you to write down on the side, arterial blood gases. When you're doing, and remember, you guys said Allen test. Remember that word? Allen test. And what do you check in Allen test? Radial and ulnar is the pulse. So radial is the radial side of the forearm and ulnar side. And you are checking ulnar why? For occlusion of radial. It shows it's a good radial pulse. That's why you are checking. But which patient do you check in your question for ABG? Before you draw the blood, what do you check? Radial and ulnar artery, that they have a good circulation, and you're checking if there is any blockage. In your another question, I'm just reminding, we all know the pulse. Do we really know when to assess? That's the part. Your question is going to be, patient has a wrist restraint, or child has a wrist restraint. And your answer is, what do? Relieve every 2 hours, and you're checking circulation. But there's another answer. Patient has a wrist restraint. What do you check? Radial pulse. That may be your answer. Why? What are we checking for circulation? The pulse. See how your answers are? Very close answer. But what is the best answer here? They're looking if you know what pulse are you checking. So you have remove every 2 hours and you have radial pulse. Which one do you take it? Check the radial pulse. How do you check the circulation? By looking at the pulse. So everyone is okay? Radial pulse. I want you to remember any question on wrist restraint, pay attention. Any question on ABG, what do you check? Radial and ulnar artery. And what is the test is called? Allen test in your question. Next is femoral. Where is the femoral pulse? Inguinal area, groin area, right here in the groin. That is inguinal area. They're not asking you pulses, where is inguinal area? Patient come back after lot of tests, cardiac catheterization. Are we clear? And I will be talking that a little later. But patient is back after cardiac catheterization. When they're putting the catheter in the heart, they use this artery right here, femoral. Where are you monitoring bleeding? In inguinal area. Are we clear? So after procedure, and I will be talking a lot of procedure, when they are giving dye, they're injecting the catheter, they go from where? Femoral area. Another question. Patient has a fracture, and patient has a multiple fracture on the femur bone. Where is the femur? Right here, thigh bone. And the bone is protruding out, and patient is having profuse bleeding. What do we do as a nurse? What do we do as a nurse to stop bleeding? You apply the pressure. You can't apply direct pressure. Where are you going now? Indirect pressure. Where are you going to apply indirect pressure? In femoral area. See how questions are? That's why I had it here. Not because you guys don't know, just to remind you. Where is the femoral? Femoral area is the groin area, and a lot of time maybe patient come back after cardiac cath. I will talk about that a little later. What do you apply here? The pressure. Where are you applying the pressure? Inguinal area. Monitor for bleeding. Patient is bleeding in thigh here. This is the artery is supplying the blood. So where are we going applying the pressure? Indirect. There are two answers. Direct pressure, indirect pressure. So indirect pressure, you're going above, which is applying, and you're applying the pressure. So that can be on your femoral artery. Popliteal space is under the knee. And where do we monitor? Russell traction. Remember when I was talking about the traction? I said Russell traction is a skin traction. Write down the word, is a skin traction. But they have a sling, and sling is going under the knee. And where do you monitor popliteal? Where is a popliteal space? Under the knee. So underline the word is, you flex the knee, and second line into popliteal fossa, and popliteal pulse is sometimes difficult to palpate, but your answer is popliteal pulse is under the knee. Write down any question, you're looking under the knee, you're checking, and a lot of your question may be if you will see Russell traction. So Russell traction, you're monitoring is what? Is the pulse, okay? Dorsal pedalis pulse. Where is dorsal pedalis pulse is? In near the first toe is foot. And in your right down on the side, the foot. Place the finger between the great toe and the first toe and groove between the tendon of great and the first toe until the pulse is. So you are checking the foot. Question, patient has foot ulcer. And patient ulcer is not healing. What would you do the first thing? You have been doing treatment and patient is diabetic and patient has a foot ulcer, it's getting bad. And there's answer. Notify the doctor, notify your RN, change the treatment, and they have another answer. Feel the pedalis pulse. Why? What are we checking here? Circulation. Before you call your RN, before you call your doctor, aren't you going to assess if patient has a good circulation on the foot? Are we clear? See how you will read your question. That's what I'm giving you some ideas. Any question on wound care? If the wound is not healing, what do you check first thing? Circulation. Because you are a nurse, you are already assessing. You called the doctor and said, I'm doing treatment, but my treatment is not working. But you didn't tell the doctor. Doctor is not coming and checking the pulse, but you didn't tell. Doctor is not going to order to do the Doppler. Doctor is not going to plan to assess his circulation. But what did doctor will order? He might order to do another treatment. But if you are a good nurse and you say, doctor, there's no pulse, you already alerted the doctor. And what a doctor is going to order here, before when he ordered the treatment, he's going to say, I want to check for circulation. And what are they doing? A Doppler study. And Doppler study will tell them if the circulation is good or not. So they can plan either amputation, patient may not be keeping that same treatment, is never going to heal because patient has no circulation. So wound care, first thing what do we assess? Is the circulation. And that's why the pulse may be on your foot treatment. Ankle treatment, maybe you have posterior tibial pulse and you have below, underline the word medial malleolus and ankle bone, and you're checking on the ankle area. And that can be on your circulation. Next is apical pulse. Everyone knows apical pulse. You may get the picture on apical pulse to assess, and you must check apical pulse. And you're checking for 1 full minute, and also you will go, is very important line is, if you can look on your package and maybe on the 3rd paragraph, is palpate the second intercostal space. And then you move downward, and where do you check? Underline the word 5th intercostal space. And also, in the last word, if you guys can find it, it says point of maximum impulses. And that word is called PMI. Sometimes they don't say apical pulse, and they use the word is point of maximum impulses. What do you monitor? Again, highlight the word 5th intercostal space, but I want you to add one word, left to the sternum, and it's close to the near mid-clavicle area. Everyone make sure add the word mid-clavicle area. That's time, a lot of questions. Clavicle, mid-clavicle area. So everyone should know the word PMI, point of is maximum impulses. You're checking 5th intercostal space. And where do we have 5th intercostal space close to mid-clavicle area, mid-clavicle area. So highlight that, and you must know apical pulse. Everyone knows about that, but I'm reviewing you. Now question on blood pressure question. Blood pressure question. Patient should not smoke, rest, no caffeine before you check the blood pressure. Let the patient relax. Next line, cuff size, very important. A person is bigger, you need a bigger cuff, you need a smaller cuff for the child and a smaller person, because cuff should be how much the arm should cover, 40% of the arm, underline that word, and higher, and if you have cuff is too small, the higher the reading would be. And if you have bigger, the reading would be low. So it affects the reading. So very important, the cuff size. And also relax your patient. And then you go into is where you do not use on any catheter. If they have shunt, any tubing on there, do not use that arm. Now if you look in your package and in maybe in the bottom few lines, palm should be facing upward. So palm facing upward. You're putting the blood pressure cuff here, and what it should be above, it says 1 to 2 inches above in antecubital area. So what is this word is called? Antecubital area. So it should be above 1 to 2 inches, your cuff, covering 40% of the arm, and the palm should be facing upward. Then you will go, upper arm must be held, and underline the word level of the heart. At the level of the heart is important. So when you're taking blood pressure, everyone is okay, antecubital area, above 1 to 2 inches, leave this open because you put the, here is your stethoscope here, so you got to have a space, and covering 40%, and your question may be below the level, above the level, or what level? At the level of the heart. Those are few key wording on your blood pressure. Make sure you check the blood pressure assessment for your pain scale, because what happened? You are in pain, what happened to the blood pressure? Is higher. Some question may be, what do you check to assess the pain? Vital sign. And what vital sign you're looking is the blood pressure. So everyone knows how to check. Simple question, but they're going to give you all these on your question. Now I'm going to move on a little bit. The part is called discontinue Foley catheter. Now doctor calls you, a doctor come in and write a order, DC Foley catheter. Now before DC Foley catheter, you should do bladder training. How do you do the bladder training if you're going to DC the catheter? How do we do the bladder training who has Foley catheter? Yes, but what would you do with Foley catheter? Clamp it, somebody said here, clamp it, very good. So everyone remember, before we do remove the catheter, some doctors will write orders, sometimes don't write it, but it's good to give them bladder training. Why? Because every time the urine is draining, and when you remove the catheter, what would be the problem? Patient is going to be incontinent, or patient is going to retain the urine because their muscles are not used. So what do you do for your patient when they have Foley catheter and you're going to remove it? Clamp it for 2 hours and release it for 15 minutes. So write down just simple word, clamp. Any question come? Yes, you guys, somebody said clamp, that's very good. Clamp it for 2 hours. And then you release it, unclamp it, you can use the word unclamp, and unclamp or release it for 15 minutes. Why? When you are clamping for 2 hours, the urine is staying back in the bladder. And what does it do? It gives them time to, bladder is expanded. And when you relieve it, it's contracting. So relaxation and contraction. And what are we giving here? Training the patient's bladder to prevent them incontinency and retention. So everyone, when you're removing Foley catheter, any question, bladder training is important. What do? You clamp it and unclamp it. Before you're going to do catheter, what kind of the procedure you will call when you're removing? Is it a sterile procedure, or it is a clean procedure, or medical? Remember two words. Medical is sepsis, and surgical is sepsis. When they use the word in your question, medical asepsis means clean technique, and surgical asepsis means a sterile technique. Is removing a catheter is a sterile technique? No, it's a medical asepsis and clean. Do you have to use a sterile glove? No. What glove do we use? Regular glove. And why? Because you are removing. The catheter was already in. And what do? Deflate the catheter. Now what are we doing here? Deflate the catheter. Patient may feel pain and also is monitor afterwards in third line, if you will see, for after you remove. Now your question. Everyone is okay? How do we remove catheter? Deflate one. Okay, what do? Deflate. Question they give you. Doctor ordered to remove the catheter. One nurse has already removed 10 ml of water from the catheter. And now you are going and removing the catheter. That's just the wording of your question. And patient is in pain. What would you do when you're removing the catheter? And they already worded, confusing you. And what are they confusing? The nurse already removed some water. And now you are pulling out the catheter and patient is in pain. Answer is, leave the catheter in place, turn the patient on the side, go back after 30 minutes, remove, and there's another answer, deflate the catheter. Take the answer, deflate. Maybe there is more water. Maybe somebody said they removed it, but the water is still there. Why would patient would have pain? Because you're pulling and there's a bulb inside. If there is no bulb, the catheter will not even stay. It will come out without any problem. But just wording for you to see that what do you do before you remove catheter? Deflate the catheter. Everyone is okay deflating the catheter? And even they said in your question, I'm reading this question, and these questions are very important to understand. Not all the time just to memorize, we deflate. And that confusing you, they have already deflated and now you're removing catheter, patient is having pain. Put in your mind, patient is in pain because the bulb is still there. So what do? And they may be answered, turn the position laterally, then you pull out the catheter, tell the patient to take a deep breath, and there are all kinds of answers. But what is the simple thing is here, you've got to deflate the catheter. Everyone is all right? Deflating. After deflating, your catheter is out. What do you monitor your patient? Is normal that they can be incontinent. And in the next line, monitor for voiding and incontinent. What is the meaning voiding? Now these are the type of questions, so pay attention every word to word and understand, and that will help you to read your question for your exam. Now, after catheter has been DC, what is normal for your patient? Normal is patient feel frequency. Usually frequency is sign of UTI, but patient is not used to it. That's normal here. Frequency is normal. Burning is normal here. Why? Because patient was not used to that urine coming out, and now patient feels burning. And patient you will monitor. Frequency burning is normal. Remember, after you DC Foley catheter, because patient was not used to. What are you monitoring? Incontinency. What are you monitoring patient here? Retention of urine. And how do you monitor retention? Underline the word PVR. Now here, a little bit confusion. I will explain simple and ask you to add. What is PVR? Yesterday, I mentioned the word post-voided residual. Now what post-voided residual means? Patient pee but patient does not empty completely. That means post-voided. Residual means leftover. You go to the bathroom, your patient is going and peeing, but he come back after 15 minutes, he puts another light. He need to go to the bathroom. He goes again, or patient is going frequently to the bathroom. Why? Because they are not able to empty the bladder completely. So what are the two common problems after you remove catheter? Urinary retention. In your question, patient has urinary retention. What are you monitoring? Bladder distension. That's your answer. What is retention means? They are retaining. And what do you assess as a nurse? Distension. When patient is pulling light frequently, patient is going and he's not emptying the bladder. You call the doctor and you're telling the doctor, patient is going too frequently to the bathroom and we have DC the Foley catheter. And doctor tells you, I want you to check PVR or post-voided residual void. Check post-voided residual and call me back. What does it mean? We are nurses. We are going to check post-voided residual. Everyone is okay. What is post-voided? After patient pees. So what do you do now? Patient goes to the bathroom. Patient come back. After 10 minutes, we take a straight catheter and we put it in. You get about 200 cc of urine. What does it mean? Patient did not empty the bladder. Patient is holding that urine. And what does that urine will cause if they are holding on? UTI. Are we clear? And what would be the problem may be? Remember the word I said, neurogenic bladder. What is neurogenic bladder? When you don't feel and your muscles are not able to empty that bladder, leading into what? Neurogenic bladder. Now what does your patient, you did 3 times, and you found every time more than 50 ml, patient is retaining urine. Normal is okay, 50 ml, more than 50 ml, patient has 200, 250. That means patient has what? Urinary retention. What doctor will order if you have question neurogenic bladder? Any patient is admitted, neurogenic means the nerves are not feeling sensation. And patient is not able to empty the bladder. What do you do for that patient is they need Foley catheter back again. Why? Because they are retaining the urine. So doctor will check a couple of times and this patient is not going to empty the bladder. What do you monitor for? Urinary retention. What are you preventing here, your patient? For UTI. What would be the result here? Neurogenic bladder. And what does the doctor is going to order? Foley catheter. Why? Because you don't want that bladder to be full all the time and lead to UTI. Everyone is okay? Foley catheter question. Removing catheter is a clean technique. What do you monitor after removing catheter? And these are kind of questions. I'll tell you, I'm not going more as a theory. I'm attaching all kinds of questions with your combination to understand the wording. So when you have neurogenic bladder, means patient cannot empty. Patient is going frequently to the bathroom. What do you monitor? What is the word is called? Post-voided residual. How do you check post-voided residual? By putting a straight catheter and checking the bladder. So underline that. And in the last wording, what do you do for your patient who's having after PVR is toilet training, indwelling catheter. And also you can check the one of your question I gave in the package. And the answer was, how do you check post-voided residual? Answer was bladder scanning. Are we clear? So what is a bladder scanning? You can scan the bladder and see how much they have the urine left over. So how do you check the urine amount is? By bladder scanning or PVR. PVR is post-voided residual. So I want everyone definitely to know your questions here and understand PVR. Next word, number 4, next on the same page, is incentive spirometer. Why do we use incentive spirometer? Complication. What are the complications are common here? What are the complications are common here? Are is pneumonia and aphylactosis. What is aphylactosis is? What is aphylactosis? Collapse of the lung. If patient has collapse of the lung, how do you know the sign of collapse of the lung? You can't hear the lung sound. There is no lung sound. That means the lungs have been collapsed. So what are you preventing your patient to use them incentive spirometer? Which patient are we going to use them? Which patient you will give them after surgery? Are we clear? Patient who's going to be laying in bed. Now remember, your questions are not what is incentive spirometer. Your questions are going to be which patient, and they might give you the patient after surgery. And also I want you to write down fracture rib patient. Fracture rib is very painful. And what happened to the patient? They cannot breathe. And what would lead to pneumonia? One of your complications of your patient with the fractures are on the rib fracture, pneumonia. How do you teach them to use it? The best position for breathing and to assessment, sitting position and upright position. Third line, what do you teach when they're using incentive spirometer? Very important again, breathe in slowly, not fast. No answer breathing fast, slowly. And what are you maintaining? The flow rate. There is a measurement. You can look at the side and there are the numbers. Those numbers should go. There's a little black ball and that's moving up and down. And how far it should go? 600 to 900. Underline the word 600 to 900. And hold it. And hold it for 5 seconds. Exhale through the pursed lip breathing. And you hold it for 5 seconds and you do it and give them the breathing exhale. So everyone remember using incentive spirometer. Anytime you question, you think where his patient is not able to breathe, abdominal surgery, lot of abdominal surgery, and rib surgery patient, and rib fracture patient where they cannot breathe in, you got to teach them to prevent pneumonia. After surgery, definitely incentive spirometer. Next, Halter monitoring. What is a Halter monitoring? Is a cardiac monitoring. All they can put on. You go in the hospital when you have a cardiac problem, they do ECG. But if you have a doctor and you're telling the doctor that I'm having my tachycardia or I feel a lot of palpitation, or maybe patient is taking cardiac medication, they want to assess heart in 24 hours. So I want you to write down 24 hours. Patient has to put on the Halter, and what are they checking here? It's like ECG. So what are they checking here? Cardiac assessment. So it is done for cardiac. But what would you teach the patient who is going with Halter monitoring? Keep the record and write down what activities they're doing. The meaning is what time they went for. They can do anything. You don't have no restriction because they are assessing the heart, how the heart functions in your exercise, in your rest, and whatever you're doing for your patient. So what do you tell them? They give you a form. Every time you have to write down. You went to rest, what hour, you went for jogging, and what did you do, all activities. And you do not remove until 24 hours. So that's called Halter monitoring. Lumbar puncture. Which patient do you do lumbar puncture? Meningitis. Any fever patient, they're looking infection. Consent is important. What do you tell before lumbar puncture? Patients are empty the bladder. And what position do you put on your patient during the test? Underline the word lateral or fetal position, like a baby. And what do you do as a fetal position? You bring the head close to the knee so they can insert the needle. Next is, what do you monitor after? Post-op care is in the last line, flat position. All the positions are important. So highlight the word flat. And what do you monitor patient after the procedure? Neurological. And write down on neurological headache. Why does the patient has headache? Because leakage of the fluid. Any question after the procedure? You have done lumbar puncture, patient is having headache, what do? Put the patient on the back position. Colonoscopy. What is a colonoscopy? Means is you're using and it's colonoscopy, you're looking inside the colon. It's called another word, endoscopy. And what do you monitor your patient? Colonoscopy. Sideline position. You put the patient sideline, and pre-procedure is on third line. You give enema or go lightly word. Go lightly is cleaning up the patient. And when you give go lightly, what does it happen? Patient has like a diarrhea. And at the end, there's no BM. It's all the water is coming up. And go lightly, NPO. And also, what do you monitor during the test? In the next line after go lightly, at the end, the medication is given Versed. Versed is given for sedation. And bed rest you do after the procedure. What do you monitor patient is after the procedure for perforation. What is the meaning? Perforation, bleeding, and highlight the word is peritonitis. And what do you monitor patient afterwards when you're giving go lightly? Dehydration. What do you lose when you have diarrhea? What do you lose? Your electrolytes, your sodium and potassium. Any question? What do you monitor? Any question? Patient has diarrhea, vomiting. What do you monitor? Your electrolytes, monitor dehydration. Everyone is okay, colonoscopy. And colonoscopy position is sideline, left side, which was on the second line. So you're putting them in left lateral position. And why they're looking for colonoscopy is a lot of time for colon problem or any polyps for cancer. And colonoscopy is the procedure. They cannot drive. They have to have someone to go with them. They're not admitted in the hospital. It's a procedure. They go home the same day. A lot of your questions, our patient is asking, how long will I stay? Yeah, they will go back home and they will always say, bring the driver with you, and the person need to stay with them. When the procedure is done, patient is going home. Next question on consent, and I talked about that. In consent a little bit yesterday. Patient has question in consent. Patient says, I'm refusing something for your consent. Do we force that? No, that's the patient choice. What word I said yesterday, any consent question, patient must be competent. Remember the word? And where do we find that competency? In the doctor's note. Where do you find competency? See how you're understanding the wording. Legality, you and me don't make a decision. I think he's okay, she's telling. If you really go in nurse's notes, and one nurse says patient is alert. Night nurse wrote that patient is alert at time because they're sleeping in the night time. Patient is confused. And another evening nurse wrote patient is confused. Every nurse has a little documentation differently what you observe in your patient. But who make the decision for your patient that they can do the consent? The doctor. And where do you document here? Competency. And this question comes in NCLEX and all exam. Because we must know. And if you are working and have patient and doctor said competency is not there, and you get the consent sign, and you give medication and patient died for some reason, and we go to the court, the first thing they're going to ask you, who gave you the permission to do this? Well, patient signed the consent. Let me show. Let me see. Where is the competency of your patient? So we have to show the doctor's competency. So any question? Who will sign the order? We all say patient should be alert orientated. But the meaning is very important for exam competency. No influence of your sleeping pill, no medication, patient is half asleep, patient is taking Haldol 3 times a day, but patient is competent, but patient don't even understand and you get the consent sign is not acceptable. Question, language. Patient don't understand the language, English, and you are having someone sign and patients speak different language. That's not acceptable. So remember, very important consent. Another question, patient says, I'm not signing the consent, I don't want this procedure. Patient, very alert, made his decision, you have competency, and patient refused. What do you do now? In your question, document. Another question, patient is scheduled for surgery, and patient is asking question. And patient wants to know about the surgery and did not sign the consent. What do you do here? Now you call the doctor. Now you call your RNY. Patient has question. Are we clear? What does it mean? Patient doesn't understand completely, thoroughly about it. So very simple way that you must look how you're getting consent. So that's about it. Patient has question, ensure doctor explained that. Patient refused it, document why, and say patient refused it for the surgery. Next one, EEG. What is the full word of EEG? Very important, you all should know. EEG question, consent question, electroencephalography. What are we doing here? Picture of the brain. ECG is for heart, EEG is for brain. What do you do? In a lot of questions, no coffee, no stimulant, no depressant. For your test, very important, after patient, post EEG patient come back. What do you do? Wash the hair. Why? Because they're using a lot of the gel and electrodes they're putting on patient head. After procedure, safety, we were not giving medication, 90% question, before and after wash the hair for your patient who's going for EEG. PPE is your personal protective equipment. Isolation room, you're going in and you're working with your patient. What do you remove first? What do we remove first? The gloves, because gloves are contaminated. Are we clear? So you are wearing mask, you have gown, and you are going to remove, and they're asking you, you're leaving patient's room. You're done your patient care. What would you remove first? Maybe a gown, mask, or gloves. So first thing, remember, you're removing the gloves. Then what do you remove? Is the gown. And then last thing we remove is the mask. So remember, how do you, questions are on your hand washing, questions are going to be how to remove gloves, question would be how to remove your gown. So everyone should know your procedures very carefully. When you're removing the gown, you already removed the gloves. How do you remove the gown? Untie the gown, and what do you do after you untie? Inside is your taking outside, then you discard them. And so remember, we all need to know your technique. I want you to add there CDC. CDC word is communicable disease control. And I talked about that, CDC or standard precaution. What is your standard precaution are? Gloves. Everywhere when you are coming in contact with body fluid. All your patients are standard care. Not only patient, me and you. You're coming anybody's body fluid, you must have the gloves. So what is CDC is guideline R in your question. What is CDC? Communicable control, disease control. And what is it says? Wear the gloves. Underneath you have deep tendon reflexes. And if you just to look in there, if you know, that's fine. If you don't know, that's okay. But just to show you, is no response is 0. And yesterday I said, when do we monitor DTR? When you are giving in OB, magnesium sulfate. Remember? And absence of DTR, that means there's no response. Lot of your muscular patient, lot of neurological condition we monitor. Number 12. You all remember, we are nurses, safety is number 1. And you are working and there is a fire. We all should know what to pick up your answer with fire. Now don't pick up by reading and guessing your answer. And I will advise you, remember the word is the race. What is the word race is? You are rescuing your patient first. And if there is no patient, And there may be answer, call for help, and scream for help. But what do you do after you rescue your patient? And if there's no patient, activate the alarm. So please, do not pick up any answer, what you think is right or wrong. You've got to go with step race. Are we clear? Who you're rescuing first? The patient. Second thing, you activate the alarm. Then what do we do? Confinement, closing the door. And then the last one, you bring the extinguisher. After you bring the extinguisher, what do we have to do? The word is pass. And what is in the pass you will do here? The pull, aim, and then what do you do? Squeeze. And when you are sweeping and aiming, that is the last one. Sweep is the last one. So remember, there will be question on fire. There will be question on burn patient, positioning. So remember, opening the airway for your burn patient if you have. And second, remember, is hypovolemic shock and infection. Three things are very important for your burn patients. Any questions come? What position do you do? Your patient has been burned. Open the airway. Remember, the neck should be extended. Any way you are opening the airway, you compare your question. Number 13, we talked about CPT. And CPT is chest physiotherapy. I want you to add there, the word is postural drainage. All your lung questions are bronchodilator, and then you give CPT, and also you give postural drainage. And what is CPT? We talked about chest physiotherapy. What is the best in cystic fibrosis? I said yesterday, what was the problem? Was the lungs. And what is the problem? Breathing problem. What are the toys I reminded you for your question on your exam? Is any toys when the child is sitting according to age and they're playing, because you don't want them to do any exertion, they can breathe. Any question on breathing questions are, you're giving CPT, and what is the best time? Early morning, or 1 hour before, or 2 to 3 hours after the meal. So line 1 is important. Before you do CPT, what do we give? Underline bronchodilator. And also, I want you to add their fluid. Some question may be increase fluid when you're giving CPT, because it loosens up the secretion. Next line, you will go percussion and vibration. So when we are giving CPT, you're giving exercise. What are we doing here? Vibrating and percussion. What are we doing here? Percussion and vibration. And after the procedure, underline the word maintain the position. If you are giving postural drainage, what is the meaning postural drainage is you are putting your patient on different position and loosening up the secretion so they can take it out. Postural means position. They lay them on affected side and they want to drain the fluid until the fluid comes out. And last line, very important, oral hygiene. All your patient with breathing problem, you must give oral hygiene. So CPT word is very good. Next, I want to go over on bee sting question. Now, there may be all answers are correct. What do you do for your patient who has a bee sting is on your question is number 1, you may have removed the sting and you may have assessed ABC, means the first thing is very important, airway. Everyone, what do you do for bee sting patient are? Is anaphylactic reaction. What do you maintain here? Airway. Now, it does have all the answers. Squeeze them, take it out, use, and do not use the tweezer. You can scrape them and clean them. But your first answer is what? Airway. Everyone is okay. Bee sting, what do you do? First thing is, keep it in mind. Airway is priority, then you're removing the sting. Yeah, you do remove the sting. But what is the priority here is airway. Bone marrow aspiration. Where do we remove the bone marrow? From superior and iliac crest. Where do we remove it? From superior iliac crest. You can also remove from sternum and vertebra, but the best and common site is superior iliac crest. Cardiac catheterization. Your patient has cardiac problem, patient is going for cardiac cath. What do you do? Number one, consent. Allergies, NPO is important. After patient come back, what do you monitor? Very important, bleeding. And what do you apply here? Pressure. Maybe they can use the word is sandbag, dressing, pressure dressing, anything in your answer. Bed rest is important for 4 to 8 hours, and tell the patient to keep the extremity extended. That means don't bend the leg. So how do they go cardiac cath? They can go from the groin area and they can go from antecubital area. Any part, if they've used here, is keep the arm straight and keep. Why? If you're bending, it can lead to bleeding. So what do? Extend it. These are exactly wording that we should know. Keep the leg extended, pressure word, and neurovascular assessment, hematoma, and the last word is peripheral pulses. Peripheral means on the leg, away from the heart. When you can feel the pulse, that means patient is okay. So cardiac cath, what do we monitor? Everyone knows bleeding, pulse, neurovascular assessment, bleeding, hematoma. You must notify immediately, or maybe one answer only. You have a patient come back from cardiac cath. What are you monitoring? Is the bleeding. What do? Apply the pressure. Next is cardiac cath. After cardiac cath, bronchoscopy. Bronchoscopy, they're going to look in the lungs. And what do you keep the patient? I want you to add before bronchoscopy, NPO, because they're going through the mouth. And we want to prevent them from is aspiration and vomiting. And what do you do after? They're viewing the respiratory, pre-op, NPO, post is gag reflex, and perforation mean is bleeding. So what do you monitor afterward? And they give you a question, and they say patient came back after bronchoscopy, and patient blood pressure is low, pulse is high, they're bleeding, they're going in shock. Patient is having breathing problem. That's not good, there's something wrong, you call the doctor, notify any breathing problem. Any shock symptoms, that means they're bleeding. So what are the, before you give anything to swallow and to eat, what do you check? Gag reflex. So gag reflex and bleeding is good. I want to go over endoscopy word. Anytime they give you question, endoscopy means inside the body they're viewing. Endoscopy is for your GI patients. What is endoscopy? I'll have you guys just write down 1 or 2 words on the top. As you see your question, patient is going for endoscopy. Endoscopy means they're looking through your GI system and they're looking into EGD and ERCP. Just write down these 2 words on the top. EGD means they're looking into esophagus and the stomach and the duodenum. E means esophagus, G means the stomach, gastric, and D means duodenum. This is your upper GI is area you are monitoring. What is in GI, we said, is your gastric and hepatic. So if there is something wrong in the pancreas and gallbladder, they do this ERCP. It's a long wording. Endoscopic retrograde cholangiopancreatography. CP, ERCP, long word. It's a very long word. If you can't memorize, that's okay. But any question, patient has pancreatitis, patient has pancreas cancer, what test the doctor would schedule, your answer would be ERCP for pancreas, for gallbladder. For stomach problem, patient is going EGD. Patient has ulcer. Patient is bleeding. Patient has liver cirrhosis. Remember, I said, which are the patients are bleeding? Which are the patients are bleeding? Who have ulcer or liver cirrhosis. And what are they are having here? Vomiting. So patient is scheduled endoscopy. Remember, immediately they're going to put the scope through the mouth and they're looking your GI system. So what would you do? So underline the word upper GI. It says esophagus, stomach, and you do have EGD word. NPO is important. And it is the procedure, conscious sedation. Patient is awake. Patient is aware when they're doing this procedure. And what do you monitor for your patient afterward? Gag reflex before you give, and adhere, pain, dysphagia, dyspnea, bleeding, and write down the word perforation. All your tests when they're going through the mouth, gag reflex and perforation are important. 3 procedure you monitor. Cross out all those last 3-4 lines. It doesn't go with this. Endoscopy, only NPO you remember, gag reflex, and you monitor for this. Thoracentesis, important, the word is thoracentesis. Patient is scheduled for thoracentesis. What do you do for your patient? Number 1, underline the word consent. Second line, in the first line, tell the patient. Your question is, patient is going for thoracentesis. They are making sure that we understand what is thoracentesis. Thora means they're going into the lungs. And what would you teach your patient here is do not move. Do not cough. Why? If they cough and they move, what happens is you're going to puncture the lungs. And if your question is, patient is having cough and patient is going for thoracentesis, what do? Give them the cough syrup, okay? And turn the patient. What side do you turn? After the procedure, turn them on unaffected side. What side do you turn them? Unaffected side. So those 2 things are very important, not to cough and turn them on unaffected side. So, and I want you add one thing is, where do you insert the needle? Where do you insert the needle when you're doing thoracentesis? Where do we insert the needle? In pleural space. Write down the word pleural space. Where is the pleural space is? Around the lungs. Around the lungs is the pleural space. Next is, I'm going to talk about the suction and tracheostomy question. We did talk a little bit, but this is a little bit more. Everyone needs to know. Monitor is for tracheostomy, sanguineous exudate. Look at around the tracheostomy area. Position, if you're suctioning and you're looking and assessing semifoulers. What do you give for communication? We did one question, pencil and paper. What do you wear in your suction question? Our mask. Very important, you use mask. Why? To prevent splashing. Then I want you can skip 2 lines and go sterile technique. A sterile technique. How far you insert the catheter? 5 to 6 inches. What kind of suction do we do? So if you can find it, sterile technique, and make sure you highlight. And what is the suction is called? Any question? Intermittent suction. We don't pick any answer continuous. There's no continuous suction. So what do we do? Intermittent suction. How long do you suction your patient? How long do we suction our patients are? Underline the word where it says 5 to 10. Add there 5 to 15. Up till 15 seconds is normal. Up till how long? 15 seconds is normal. What does the problem when you're suctioning your patient? What does it happen to the patient when you're suctioning? What happened to the patient when you suction too long? They're not breathing. What is the right wording? What is the terminology word? Very good. So what does it cause? Hypoxia. Remember the word hypoxia. So if you keep on suctioning too long, we are cutting, you guys said, cutting off oxygen. And that means patient is not getting oxygenation. So remember one word, intermittent. How long do we suction? 5 to 15 seconds. Then you will teach, before your suction, you take a deep breath. And very important, the last few lines are pre-oxygenate and reoxygenate. Everyone highlight the word pre-oxygenate. So what do you do before suction? Pre-oxygenate. Make sure patient has enough oxygenation. Reoxygenate means is you are giving more oxygenation. Question, you suction one time, patient has a lot of phlegm, and what do you do for your patient if patient has a lot of phlegm? What do you do? Resuction. And what do you do before you resuction your patient? Reoxygenate. Remember, before resuction, give oxygenation. And also is check their oxygen level. And next page, you guys have cleaning inner cannula. I said yesterday, what cannula we remove? Only inner cannula. And highlight the word, you have wash your hands, we all know, but make sure inner cannula. Now don't go for wash with soap and water, we don't do that. Mostly you go with your rinse with normal saline, you're wearing sterile technique, and clean with hydrogen peroxide. Because hydrogen peroxide takes away all the thick phlegm. Suction through the outer cannula. Now, and also last line, you can use the gauze. And remember, I said when you are changing the tie, what do you remember when you're changing the tie? Put the new tie, then you remove the old one. What do you keep in the room for your patient when you're suctioning? What do you keep your patient in the room? Your suction machine, you have gloves, and what else I said yesterday, if you have your tracheostomy patient, what do you keep in the room? Available obturator. Remember the word? Obturator. What is obturator? If the tube comes out, that you have a part that you can leave it open, and the word is called, it's like a clamp, and it's a metal, you can insert and you can open the airway. Are we clear? So what do you keep? And same size of extra tracheostomy tube. What size of tracheostomy tube? All your suction patients, everyone should know what are we looking in there. Now, next is on your shaving question. Now, if ever it shows in your question, you go with the grain of hair and pull the skin taut with non-dominating hand. So any question on shaving, monitor for bleeding. Any patient has nick and bleeding, need to notify, but pull on the side, and also you go with the grain. Hemovac. Now I want, before we go on lunch break, to finish two things, and then whatever left we come back and I'll try to finish that and then give you the answer, then you can go home. But if Hemovac is one, then you have Jackson Pratt, and third one, I said the Penrose drain. There are three kinds of drain we have. Patient, we come back after surgery, I want you to highlight the word Hemovac. Hemovac 1, and you have is Penrose drain, and you add there, and you have on the third or fourth line Jackson Pratt. So how do you empty Hemovac? Question, how do you empty the Hemovac? And what do you do when you empty the Hemovac? Remember one thing, is you guys, you open it, and when do you empty your drains are? Hemovac, and where do we use Jackson Pratt? Where do we use Jackson Pratt for your patient is cholecystectomy. What is cholecystectomy? Removal of gallbladder. And you will see that. Jackson Pratt is small. I'm sure you guys have seen. Hemovac is more like a round shape. It's a drain. And question can be, how do you empty the drain? And what do you do when you empty? You write down in your output. When do you empty? Don't pick up your answer when full. You empty at the end of the shift. When do you empty? At the end of your shift. And what do you do when you empty? Third line, airtight circuit to prevent contamination. And what do you do is, it's you open it, you drain it, and then you remember, you may not have few lines here, but I add on the side, you compress completely. The thing is, you got to remove, before you are putting it back, remove the air. You put on a flat surface and you press it down, remove the air. And sometimes they will question, how do you remove negative pressure? By removing the air. Then you make sure you clean. Everyone is okay, put on a flat surface, press it down, empty it, and reattach the hemovac. Jackson Pratt, the same thing. Penrose drain are very small. And where do we put Penrose drain? Patient with appendectomy, like small incision. What is Penrose drain? They don't have any bag. They are like a tubing, and they just put it in, and the drainage is coming out on the dressing. And it helps them because it keeps the wound open. So your question can be, patient returned back. What do you monitor? After the surgery, you're monitoring the drainage. And what are you using for your patient is hemovac, number 2, Jackson Pratt, and the Penrose drain. So that covers here for your drainage system, empty at the end of the shift. If the drainage is increasing and any foul smelling, sign of infection, you notify the physician. Positioning, I know we all know the positioning, but why do we have here? Which position? I usually used to do all that before, then I used to move on med-surg, but I realized med-surg and others are more important by the time we're done, and I'm going back. So now you guys have already done. Tell me, where are we going to use log rolling position? Which patient? Spinal cord injury. How about scoliosis question? Yes. So remember, is spinal cord injury. Tell me, we studied already. What is the complication of your spinal cord injury patient for your exam? And I have talked about that there.
Paralysis.
Very good. Paralysis, but what is another complication? Yes, that's good. Very good that you know is a paralysis. That's good. But what is main complication you have patients when they have spinal cord injury? Yes, you monitor respiration complication. Yeah, patient is paralyzed. And what is the complication patient has here? Anybody remember the word autonomic dysreflexia? You guys need to know that. We have done that. See how your questions are. Autonomic dysreflexia. And so, when is your position is, number 1, log rolling. Log rolling position you're using for which patient? Scoliosis. Spinal cord injury. I want you guys gave good answer, but we don't remember what is the complication is here. Autonomic dysreflexia. What is the sign of autonomic dysreflexia? What was the one thing I want you to remember for your test is what's that stool softener? It's okay. All right. They are constipated. We can go for that stool softener. That's okay. That's a good answer too. But let me remind you guys, the connection is important. Understanding is good. Your question is going to be, patient is admitted with autonomic dysreflexia. And I say, what is the problem here? Because they cannot pee, they cannot have bowel movement. What happened? Pain. And what does the pain take say? The blood pressure. So what is autonomic dysreflexia? Hypertension. What do you do? The first thing, lower the blood pressure. How do you lower the blood pressure? raising the head of the bed. And what do you check later on? The bladder. What do you check later on? The BM and constipation. Let me quickly go. Sims position is your left lateral position. Sims position, never pick up right. Right is no. All your enema. Colonoscopy. Suppository. What position do we go? Sims. Number C, orthopenic position. Where do we go orthopenic position? COPD patient. Patient who cannot breathe. And they're sitting upright and they can breathe. Orthopenic position. Trendelenburg position. Where do we? Short. Very good. And we use the word modified. The meaning is not too high. Modified, but short. What do you monitor for shock patient? What do we monitor patient who's in shock and they are maybe hypovolemia? Number one. What are the other patients you're going to monitor shock? Dehydration patients. Why? What is dehydration? Hypovolemia again. You're losing blood, you're losing fluid, and that is shock. Prone position, we said already today, is tonsillectomy, amputation, and cleft lip babies. Next is lithotomy position. Where do we go lithotomy position? Pelvic exam. And mother is having a baby. What position is that? Lithotomy. Lithotomy position is also used when the doctor is checking the bladder. What is the bladder is? Cystoscopy. Cysto means the bladder. Cystitis means UTI. So cystoscopy question, what position? Lithotomy. What is a common problem in lithotomy position? The legs are up, maybe cramping. Patient says, I'm having a leg cramping. That's normal. Why? Because patient was in cramping. Patient was laying in a bed and on a gurney or on the table for examining that long. What do you assess them? Get them slowly. Safety. Not very hard question. What do you monitor your patient? Prevent them from fall. I will stop here and you can.